All right, let's talk about total hip arthroplasty, or THA. This is really the definitive surgical move for anyone with end-stage hip problems. We're going to dive into everything you need to know, from the nuts and bolts of the prosthesis itself to what happens after surgery and the complications to watch out for. So here's our game plan. We'll start with why and when we do a THA. Then we'll get into the implant itself. After that, we'll cover the absolutely crucial recovery period, look at the potential complications, and finally, we'll wrap it all up with the key take-home messages.
Okay, first things first. Let's set the clinical stage here. What are the signs that point to needing a total hip replacement? It really all comes down to the underlying pathology that pushes a patient towards this kind of intervention.
At its heart, THA is the gold standard for advanced osteoarthritis. This is that chronic, irreversible disease that just wears away the hip's articular cartilage, which in turn causes some pretty profound changes to the entire joint.
So what does this actually look like when a patient comes into the clinic? Well, you're going to see someone with pain that gets worse with movement and weight bearing, and eventually it's so bad it wakes them up at night. Their range of motion is shot, especially when it comes to rotation, and they might even have developed contractures. And you'll notice the way they walk, that claudication and a positive Trendelenburg sign, where the pelvis drops on the opposite side when they walk. These are the classic signs that tell you conservative treatments just aren't cutting it anymore.
So now that we've covered the why of a THA, let's get into the what. We're going to break down the actual implant, what it's made of, its different parts, and how we actually attach it to the bone.
Every single THA implant has these three basic parts. You've got the acetabular cup, which replaces the hip socket. Then there's the femoral stem, which goes right down into the femur. And finally, the femoral head sits on top of that stem and moves within the cup, perfectly recreating that ball and socket joint.
Now, here's a really critical decision for the surgeon: how to secure these parts. There are two main philosophies here. You have cemented fixation, which is kind of like using grout to get immediate stability, and then you have uncemented fixation, which actually encourages the patient's own bone to grow right into the implant.
This table lays out the differences pretty clearly. With cemented fixation, you're using something called polymethyl methyl acrylate, or PMMA, which gives you rock-solid mechanical stability right away. Uncemented implants, on the other hand, are designed to be osteoinductive. Their porous hydroxyapatite-coated titanium surface actually invites the patient's bone to grow into it, creating a long-term biological bond. And of course, you can mix and match with a hybrid approach, often an uncemented cup with a cemented stem.
The choice of the bearing surface, the part that actually moves and articulates, is hugely important for how long the implant will last. This is where all the wear and tear happens. The most common combos are a metal or ceramic head moving against a liner made of ultra-high molecular weight polyethylene, or UHMPE for short. A ceramic-on-ceramic pairing is another fantastic low-wear option.
All right, the surgery's done. Now we shift gears to something that is arguably just as important: the immediate post-op care. This phase is absolutely 100% critical for a good outcome. For those first 24 hours, these patients are usually in an ICU setting, not a regular ward. You need that level of close observation to manage pain, watch for any immediate complications, and just make sure they're hemodynamically stable after such a major operation.
The protocol right after surgery really boils down to these four pillars. First, positioning is key. You want the limb at about 10 to 15 degrees of flexion and in a neutral rotation to protect that new joint. Second, prophylaxis. Got to prevent blood clots and infection. Third, you need excellent pain control to keep a patient comfortable and help them move. And fourth, physiotherapy starts almost right away, with a huge emphasis on mobilizing safely.
Now here's a huge milestone every patient wants to know about. While they'll be up and moving early with help, putting their full, unsupported weight on that new hip is usually off limits until about the 6-week mark. That gives everything time to start healing and for the tissues to integrate.
The number one goal here is making sure that new hip stays where it's supposed to, and that means the patient has to be incredibly strict about certain precautions to prevent a dislocation, which is the most common early problem. So, what are those precautions?
Physiotherapists will drill this into patients. There is an unsafe range of motion they absolutely have to avoid. No bending the hip more than 90 degrees, so forget about low chairs. No adduction, meaning you cannot cross your legs, and no excessive external rotation. Following these rules religiously in the first few weeks is just paramount. It lets all the soft tissues around the hip heal and create the stability that new joint needs.
You know, even though THA is one of the most successful operations in all of medicine, it's not risk-free. So let's go over the most significant potential complications. We can kind of split them into general risks and ones that are specific to the hip.
These are the risks that come with any major joint replacement. Infection is always a huge concern, both right after surgery and even years down the road. Aseptic loosening, which is a long-term problem caused by wear and tear, can make the implant fail. And of course, you've always got the risk of blood clots like DVT and PE, plus the potential for injuring nearby nerves and vessels during the operation. So beyond those general risks, you've got a few that are specific to the hip. First, as we've talked about, dislocation is a major worry early on. Second, some patients might deal with a more chronic feeling of instability. And finally, getting the leg lengths perfectly equal is a real surgical challenge, so sometimes a noticeable difference can happen.
Okay, we have covered a lot of ground. To finish up, let's just boil all of this down to the most critical, high-yield points that you should walk away with. So let's recap. 1. THA is the go-to treatment for end-stage hip OA. 2. The prosthesis has 3 parts, a cup, a stem, and a head, and it's fixed with or without cement. 3. Post-op care is huge, focusing on preventing dislocation and blood clots. 4. The big complications to watch for are infection, loosening, DVT, and dislocation. And 5, that 6-week mark is the magic number for returning to full weight bearing.
And we'll leave you with a clinical question to connect all this knowledge to real-world surgery. Really think about how the patient in front of you changes the game. For example, why might an older patient with weaker bone be a much better fit for a cemented prosthesis that's stable from day one? And on the flip side, why would you lean towards an uncemented one for a younger, more active patient, banking on that long-term biological fixation? That's really where the science of this procedure meets the art of surgery.